Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome to the channel of Stand Medical Notes. So, till now we have discussed the definition, different guidelines, classification, target organ damage, pathophysiology, and primary and secondary causes of hypertension. So, from today onwards, we'll learn uh, about the management of the hypertension. Management of hypertension. Let's begin with the name of Almighty. So, what are the aims of management? So the aims of management are first to make a diagnosis of hypertension. Okay, how do you make diagnosis of hypertension? There are three methods of measuring the BP. Number one is a palpable method, palpable, palpatory. Sorry, not palpable. It is called as palpatory method. Palpatory, palpatory method. Number two is auscultatory, which is the gold standard to measure. Auscultatory method. And number three is oscillatory method, which is not very much used but used by the experienced practitioners. And this oscillatory method is the method which is used in the automated BP machines. Automated BP machines. Auscultatory, what do you do? In palpatory, what you do? You just you tie the cuff to the patient to the right arm or left arm, so that the cuff should cover the 80% of the circumference of the shoulder, and it should be one or two fingers breadth away from the middle crease of the cubital fossa, and you inflate the cuff, and simultaneously you palpate the radial pulse. The point at which the radial pulse, the last of Hg where the latest radial pulse disappears, is nothing but the SPP. So by palpatory method, you can detect only systolic blood pressure. In auscultatory blood pressure, you inflate the cuff above the systolic blood pressure, and you will hear two sounds: first sound, and then second sound, and then no sounds. When you deflate the cuff, so you will have first sound. That first sound, appearance of the first sound is nothing but the SBP, and then there will be disappearance of the sound. Again, there will be appearance another sound, that is nothing but the DBP. Okay, so auscultatory you measure both SBP and DBP, but palpatory only SBP. So the usual procedure is first you do palpatory and then auscultatory to every patient. First you do palpatory, then auscultatory. That's how you measure SBP and DBP. Okay, so you diagnose the hypertension. So all the thresholds were discussed yesterday for home BP monitoring, for office BP, for automated BP monitoring, and daytime what should be the threshold, and night time while the patient is awake, while the patient is asleep. All things have discussed. Okay, then first is diagnosis. Second is, and one more point in diagnosis is, if the BP is more than 180 systolic or 110 diastolic, then it is diagnosed at that point of time only, and you send investigations and see all these things. Okay, these visiting more than two visits are only required only if the BP systolic is less than 180 and diastolic is less than 110. Okay, so sorry, so first you have diagnosed, then what you do, you take history and examination from the patient. In that history and physical examination, okay, and then investigation. By taking history, physical examination, then investigation, you identify the type of hypertension, whether it is primary or secondary. Okay, then second is you identify whether there is any target, whether there is history, whether you find anything in history, physical examination, and investigation, findings of target organ damage. Then you exclude the secondary causes. Then after that you assess the cardiovascular risk. There are many calculators for this, so mentioned here in these notes is the Framinghams score to assess the cardiovascular risk. Okay, so next is quad score. These are all available in online calculators. The most recent and the most latest score which is used is the prevent score. Remember this one. Prevent score is the most latest one which is used nowadays. Okay, then you plan for treatment, which includes lifestyle advice and drugs. Okay, so these are the aims of our treatment. So first you diagnose, then identify target organ damage, secondary causes, exclude, and assess CV risk, and then treatment. So coming to the history and physical examination, what is the important points you should ask the patient in history? Okay, so first you ask the duration of the BP. You have detected now that BP is more than the threshold value. So ask the patient, when was the BP first noted high, and whether multiple readings were taken for the BP, and what are the circumstances when the BP was taken at that time, uh, and at now also, right now also. So whether in previous BPs, previous multiple examination for any purpose, if the BP was high, you should ask the patient. And what were the circumstances? What was the condition for which the patient was was reported to the hospital? Okay, that circumstance you should ask. So important to remember is in pain and stress and illness, the BP in stress and usually in pain and stress, slightly the BP is raised. When there is pain and stress, slightly the BP is raised. So whenever there is pain and stress, you shouldn't take that BP. So when the patient is pain free or stress free, then you should measure the BP. Okay. So if the BP is if the BP was repeatedly above the threshold value before in the previous measurements, and there were no such factors like pain and stress, okay, which aggravate the BP for some time period, then this BP serves as the confirmation BP. No no multiple visits are required, and this visit will serve as a confirmed BP, and you can confirm it as a true hypertension or transient hypertension if the BP was not elevated in previous readings, and now also if the patient is not having any pain stress. Okay, transient if pain stress is having, definitely BP is slightly increased, and you should exclude white coat hypertension also. So what will, by doing this, what things you do, you will differentiate between true hypertension from the transient and white coat hypertension. So how do you differentiate? So in previous visits there will be no BP elevation, and if at all it was elevated, sometime it will be normal, sometime it will be at the threshold value for some time, and the circumstances can be pain, stress, and illness. So it was not true hypertension. Okay, and if now you are recording, you need to take multiple visits. But if the BP was measured and repeatedly it was high, and there were no circumstances like pain, stress, illness which transiently elevate the BP, then it is a true hypertension. That's how you differentiate true hypertension from the transient or white coat hypertension. So this is an important point. Okay, then you ask for symptoms of hypertension. So remember, Oxford says only 20% of patients experience symptoms of hypertension, and most patients who have headache and who think that the headache may be due to hypertension usually have that hypertension because of their thought of headache, thought of BP, not due to BP, thought of BP. But even then, if at all there is headache in 20% of individuals, that headache of BP will be occipital, in the occipital region, and it will be in the morning. In the occipital region, it will be in the morning. Symptoms of headache you should ask. Symptoms of dizziness you should ask. Symptoms of palpitations. So this is CNS, headache and dizziness, then palpitation, CVS, then eye visual blurring, and epistaxis from the nose. So whether any of these are present or not, you should ask to the patient. So if one of these or one or more of these is present, then this suggests uncontrolled or severe hypertension. Uncontrolled or severe hypertension. So occipital headache in the morning, epistaxis, recurrent epistaxis particularly, and Woodruff posterior bleeding will be there, not anterior, posterior bleeding. More specifically, posterior nasal bleed, and palpitations, history of palpitations, and history of breathlessness, okay, dizziness, all these things. So these are the symptoms which you ask. So that is the symptoms you ask to the patient. The next, so that will help us to know that the hypertension is severe or uncontrolled. Okay, ask the symptoms of target organ damage. Okay, there are 4 important organs which we have discussed. Heart, you should ask the symptom of chest pain, dyspnea on exertion, orthopnea, paroxysmal nocturnal dyspnea, palpitation. If at all these are present, then it can suggest coronary artery disease, LVH, heart failure, arrhythmia, AF particularly. Brain, ask any history of transient ischemic attacks, history of stroke, history of any facial or upper or lower limb weakness, history of speech difficulty, very important, history of speech difficulty, and history of memory decline, that is nothing but dementia. Okay, so this is So history of TIA, stroke, weakness, speech difficulty, memory decline. If at all it is present, then it suggests cerebrovascular disease. That is a target organ damage. Then next comes the kidneys. For kidneys, ask for morning facial puffiness, especially around the eyes. Okay, swelling around the eyes, especially in the mornings. So facial puffiness you ask about. Nocturia is the earliest sign of CKD. Remember, nocturia is the earliest sign of CKD. Any frothy urine, suggesting a urinary tract infection. Reduced urine output, again suggesting CKD. Okay, so these you should ask. The first sign, the first and first, the earliest sign of CKD is nocturia. Remember, but there are other causes in benign prostatic hypertrophy, or BPH is the most common cause in, or some patients who are on diuretics, they also develop nocturia. But the patients are not taking diuretics, or they don't have BPH, then nocturia is the earliest sign of CKD. And facial puffiness, very important, and reduced urine output and frothy urine you should ask. If it is present, then it suggests hypertension, nephropathy. And eye, you ask for blurring of vision or transient vision loss. There was vision loss for some time period. So if it was present, then it suggests hypertension, retinopathy. So these are the history questions we should ask in the history. So that's about the target organ damage. Target organ damage. Okay. Now you should ask questions regarding to exclude secondary hypertension in these patients. For example, so secondary hypertension, mainly I said renal and endocrine are most important. So renal, you should ask for any history of recurrent urinary tract infections, any history of cola colored urine or reddish urine output, and any history of flank pain, any history of stone, urinary kidney stone disease, any history of childhood kidney disease. All these you should ask. Urinary tract infection, blood in urine, flank pain, stone disease, and childhood kidney disease. All these indicate renal parenchymal disease. Second comes the endocrine cause. So in endocrine cause, if there is a triad of episodic headache, sweating, and palpitation, headache, sweating, palpitation, episodic, and fluctuating BP is present, and if you be ACE inhibitor, the patient goes into AKI, acute kidney injury, or the patient will have increased BP, then it suggests pheochromocytoma. Okay, sorry, not AKI, ACE inhibitors. I'm sorry. If you have this triad, episodic headache, sweating, and palpitations, then it suggests pheochromocytoma. If the patient has weight gain, fatigue, cold or heat intolerance, then he may have hyper or hypothyroidism. Okay, so this was not discussed in the etiology in secondary hypertension, so you should keep this also in mind. But you should also remember, bear in your mind that Cushing's syndrome patient also initially present with weight gain. Okay, but thyroid is more common than the Cushing's syndrome. Okay, then if the patient has history of muscle weakness and cramps, muscle weakness or cramps, then that suggests hyperaldosteronism, nothing but Cohen's syndrome. So that's how you rule all these things. So for pheochromocytoma, triad. For thyroid disorders and hyperaldosteronism, these three endocrine disorders you should remember. Okay. Then sleep history is important to exclude obstructive sleep apnea, OSA. So how do you ask that? Patient will be snoring at night, and patient will have excessive somnolence in the daytime. Patient will sleep in the daytime, and he will not have sleep in the night time. So this is the history which suggests that the patient may be having obstructive sleep apnea, and in this patient the sympathetic nervous system is very much activated. That's why they develop hypertension. Drug history, same things. So all the causes which we have discussed, so you are asking the questions regarding those causes to the patient. So whether the patient takes continuously NSAIDs or on oral contraceptive pills, steroids, for example in connective tissue disorders, arthritis patients, herbal medications. This is very important. Patient taking continuous herbal medications, they will also develop drug-induced hypertension. Okay, so these three important. 4 you can take: NSAIDs, OCPs, steroids, nasal decongestants like phenylephrine or oxymetazoline, metazoline, xylometazoline. Okay, so that suggests drug-induced hypertension. Substance abuse, like if the patient takes alcohol, so if the patient smokes, if the patient takes drugs like cocaine and amphetamines. So drugs, smoking, alcohol, these are the modifiable risk factors. But if if they are of long term, they will develop hypertension. Family history, you should ask whether there was history of early hypertension, whether there was history of stroke in the family, whether there is history of CKD or coronary artery disease. You should ask the patient. If it was there, then there is a genetic risk. Okay, Lifestyle factors you should ask whether the patient eats spicy food, takes high salt, eats non-veg very much, sedentary lifestyle. All these things you should ask. So physical activity, stress you should ask, obesity. Okay, it guides non-pharmacological management. So this is how you take the history. Important in this history is up to here. So at the time when the patient comes, the symptoms of any uh, target organ damage you will ask to the patient, symptoms of any target organ damage. And if it is not present, so heart you ask, you remember what the heart symptoms you will ask. Okay, failure symptoms or arrhythmic symptoms or ischemic symptoms. Brain you will ask for any transient ischemic attacks, any weakness, any problem in talking, or early cognitive decline, that you should ask. In kidney we will ask for nocturia, number 1 point, facial puffiness, okay, decreased urine output, urinary tract infection, frothy urine you should ask. And eye, blurring of vision or transient vision loss. Okay, then you should exclude secondary hypertension. Renal means renovascular cause, both you should ask. Okay, renovascular cause. So renal, okay, recurrent UTI, hematuria, flank pain, and childhood kidney disease you should ask. Endocrine causes exclude pheochromocytoma, thyroid disorders, and hyperaldosteronism. Sleep history you should ask to exclude obstructive sleep apnea. Drug history, these are other causes we have discussed in other causes, no? Other causes we have discussed. So OSA and drugs you should ask. Substance use like alcohol, tobacco, and drugs you should ask. Okay, these are the important history in patient with newly diagnosed hypertension. Then coming to the important physical examination findings which you can have in patients with hypertension. Now first you measure the BP. Measure the BP in both arms. Proper cuff size. Measure both sitting and supine and sitting and standing position also. So in standing with supine, because some patients will have orthostatic hypertension, like patients, elderly patients and diabetic patients, they have orthostatic hypertension, meaning the BP will fall more than 20 mmHg systolic when they raise from the supine to the standing position. That is orthostatic hypotension. In less than 3 minutes, they will develop. Okay, baroreceptor failure. So that suggests sympathetic nervous system failure in these patients, or use of some drugs which is causing this orthostatic hypertension. So by this BP measurement, you confirm the diagnosis, and it also detects orthostatic hypertension. Now you come to the so first general physical examination. You see the patient, whether the patient is obese, whether the patient has Cushingoid features, and you see the palpebral conjunctiva, whether the patient has pallor. Pallor is important because in diseases like chronic kidney disease, there will be normocytic normochromic anemia in these patients. Normocytic normochromic anemia. So pallor is an important cause. So these are risk factors, and secondary causes will also have this. So pallor and obesity. Then you will see the pulse. Okay, see the rate, rhythm, any arrhythmias you will detect in this. And radiofemoral delay is important. Okay, so arrhythmia or coarctation of the aorta you will know from your pulse. Then BP differential. So measure the BP in arm and leg. If the difference is very much high, systolic BP is very much. If the systolic BP is more than the systolic BP of leg, then that suggests coarctation of aorta. Radiofemoral delay also suggests coarctation of aorta, and arm leg BP difference also suggests coarctation of aorta. So this is general physical examination, and these are vitals. So step by step you are assessing everything. Then you do a fundoscopy. So I said no, fundoscopy should be in hand of every physician. So you see for AV nicking, this is mild eye disease. Hemorrhages, exudates, and palpedema, this suggests severe hypertensive disease. So it helps in grading hypertensive severity and also knowing urgency versus emergency. So in urgency, you will not have any target organ damage. You will not have severe eye disease in urgency. But in emergency, you will have hemorrhages, cotton wool spots, along with the AV nicking and silver wiring and copper wiring. You will have cotton wool spots and hemorrhages in emergency. Okay, that's how you differentiate by fundoscopy. Okay, so general GP is over, pulse is over, BP is over, difference, and eyes. Then come to the neck. So neck, you see the thyroid, whether there is thyroid enlargement, whether there is carotid bruit. Carotid bruit, presence of carotid bruit suggests there can be any thrombus here, and patient may be in risk of stroke. Carotid bruit is a very bad sign. Okay, so this suggests endocrinal cause. So I will first remove this all. So in neck, thyroid you should see, carotid bruit you should see, endocrinal cause, and if there is carotid bruit, you will have you will say the patient is having atherosclerosis. Okay, and then you come to the chest. In the chest, you will see heart and lungs. So in heart and lungs, whether the apex is displaced, that means there is LVH. Loud S2 is a characteristic feature of long-standing hypertension. Whether there is S4, that means the patient is having heart failure also. And whether there are murmurs, that means the patient may be having some valvular disease. So these features suggest left ventricular LVH and heart failure. Lungs, basal captations, if they are there, then it suggests cardiogenic pulmonary edema. Okay, then you come to the abdomen. In abdomen, you see auscultate from the renal buoy and palpate the kidneys. If there are, if you feel palpable, ballotable kidneys, then that can be the sign of polycystic kidney disease. And if there is renal buoy, then that can be a sign of renovascular hypertension. Then you come to the extremities. If the extremities have edema, that may be the sign of heart failure, or it can be a sign of CKD also. Okay, heart failure or CKD. And you palpate for the peripheral pulses, in particular the dorsalis pedis artery and this one popliteal artery. Okay, so if the peripheral pulses are weak, you compare with both side limbs, then that may suggest what do you call this, peripheral arterial disease. And one more thing is, in history you should ask for features of intermittent claudication also. You see the weight of the patient, or you measure the circumference of the waist. If there is a central obesity, then the patient is having metabolic syndrome. So this is a step-by-step guide to how to take a history and physical examination in these patients. So our main aim is to diagnose the hypertension, and then to rule out target organ damage, and then to exclude the secondary causes. So history and physical examination we have done. Now you send for these are the primary investigations you should do for every patient who is newly diagnosed with hypertension. So you can divide this into, number one is blood tests, and then urine test, then ECG and fundoscopy. Four things you should do: blood test, urine test, ECG and fundoscopy. In blood test, one thing is not mentioned here, CBC. Why CBC? In CBC, if you see that the hemoglobin is equal to or less than 10, and MCV, MCH and MCHC are normal, these are all in the normal range, then this is called as the normocytic normochromic anemia. Normocytic normochromic anemia, so which is a feature of chronic kidney disease, CKD. Or the patient may be having some connective tissue disorder like rheumatoid arthritis, or SLE in particular, SLE, or systemic sclerosis. So you will have in these kind of patients, more commonly is CKD and connective tissue disorders. So this type of CBC you will see. Okay, so that will give you a clue to this picture. Okay, the next, what will be the next thing? So next you see the you send for glucose to assess diabetes and metabolic risk. Okay, the patient, some patients may pre-diabetes, they will not have diabetes, so they may have metabolic syndrome. Okay, you see creatinine and EGFR, okay, to evaluate for renal function. Then you send for lipid panel to assess for, lipid panel is sent both to know the metabolic profile of the patient, and also to assess the cardiovascular risk. Okay, because these scores, this Framingham risk score or prevent risk score, all these scores use this lipid LDL and triglycerides for risk assessment. Then in endocrinopathies, the most common endocrinopathy, TSH you will send for any thyroid disease, and electrolytes you will send to know whether there is Cone syndrome. Okay, for primary. In Cone syndrome, what you will have? You will have increased sodium and decreased potassium. Okay, so this is the basic investigation in blood. In urine, you will see for urine analysis to detect for any hematuria or proteinuria. If it is present, then it may indicate some glomerulonephritis, or it can indicate diabetic kidney disease, or also it can indicate some systemic disease like systemic lupus erythematosus or malignant hepatitis. Sorry, this is important. Malignant hypertension, glomerulonephritis, diabetic kidney disease, malignant hypertension, or polycystic kidney disease also you can have. Okay, and urinary albumin creatinine ratio. So this is not done in many labs. So particularly in rural areas, you can send for UPCR, urinary protein creatinine ratio. So if it is raised, then that suggests chronic kidney disease. And also this assesses the target organ, as we have studied in the pathophysiology. No, so two indicators of target organ damage, very important indicators, are the urine routine, and next one is the fundoscopy. So by these two you will assess for the target organ damage. In urine routine you will have hematuria and proteinuria, and fundoscopy you will have those changes of retinopathy. Okay, then you will do ECG to assess for LVH. If LVH is present, then that suggests the hypertension is long standing, and if treated early with AC inhibitors or ARBs, then this LVH may regress. The heart may come to normal size. Okay. Then you examine the retina for any hypertensive retinopathy. But fundoscopy is very much important, especially in patients with hypertensive urgency or emergency cases. Okay. Okay. Baseline, the retina will have this grade 1 and grade 2 things. That is up to AV nipping, copper wiring and silver wiring and AV nipping. Hemorrhages, cotton wool spots, hard exudates, papilledema are all advanced changes which one can see in malignant hypertension or hypertensive emergency or severe eye disease. Okay. So these are the basic first line investigations. So in blood test, what you will send for? You send for CBC, RBS, lipid profile, number 1, number 2, number 3, number 4, serum creatinine. Okay. Number 5, TSH. Number 6, electrolytes. Number 7, urine routine. Number 8, ECG. Number 9, fundoscopy. So this is the list of investigation, primary investigation. So if you suspect any secondary cause, then you can add up investigation. More commonly, which is done if you suspect secondary investigation, is the USG, renal Doppler, renal artery Doppler, and seeing the kidneys. How are the kidneys? So the most common second line investigation which is done. Okay, that's about the history, physical examination, step by step, how you will assess. So general physical examination, then you will go for vitals in pulse and BP, then you will assess for fundoscopy, then the neck, thyroid, then chest, then abdomen, then limbs. Okay. And in history, symptoms, now if there are suggestive of target organ damage. If not, then you ask for target organ symptoms, 4 organs. The next, exclude renal and endocrine causes. The next, exclude obstructive sleep apnea, and then drug induced causes, and then family history. So this is the history, physical examination, investigation patients with what do you call hypertension. Then what you will do, you will evaluate cardiovascular risk with some risk score. So here you can see, so this is Framingham risk score. So estimation of the 10-year risk of cardiovascular disease. So prevent score is the latest one, or you can also use British Q risk 3 score. Q risk 3 score. So these are Framingham risk score, prevent score. Prevent score is the latest one and mostly used, and British Q risk 3 risk score. So in that, what parameters you will see? So these are in online calculators, you will find all these things. So in these, what parameters you will see? You will see age in this Framingham risk score, HDL cholesterol, total cholesterol, systolic BP, whether treated or untreated, smoking status of the patient. See, very important, smoking status. So according to Framingham risk score, 5 things. One is age, okay, and number 2 is HDL cholesterol. Number 3 is total cholesterol, and number 4 is SBP. See, not DBP, you're taking SBP. Okay, SBP, whether treated or untreated. Treated or untreated. Sorry, untreated. Then fifth one, smoking status, smoking. Okay, so these 5 parameters are used in this Framingham risk score. Okay, so any patient according to this Framingham risk score having more than 13 points, 13 to 17 points, and more than 18 points. Okay, 18 is severe risk. Risk is more than 20, as mentioned here. I will just show you here. See here. So high risk is considered if it is more than or equal to 20%. Intermediate meaning 10, more than 10, 10 to 20. If the patient has 13 to 17 points. Okay. Low, less than 10%. So any patient having at least 13 points according to Framingham risk score will have more than 10% of cardiovascular risk, and you will deal with the patient accordingly. So that is about the risk. How do you evaluate for the 10-year cardiovascular risk? So that's about the history, methods of taking the BP, aims of management in patients with hypertension, and history, important physical examination, and first line investigation and second line investigation in patients with, and calculating the cardiovascular risk score. So I think this is enough for today. We'll discuss the treatment in the next class. Thank you.